So today, Research to Practice. This is August 27th, 2025, CAR T in North Carolina with Dr. Grover. Dr. Grover, welcome.
Yeah, thanks so much for having me.
Absolutely. We're looking forward to having you back. So it's been a while, I think.
Yeah.
So let's see. I'm not going to read that whole bio. I'm going to do top facts here. So Dr. Grover is actively involved in multi-center clinical trials and collaborative research efforts aimed at expanding treatment options and improving quality of life for patients with lymphoma. So far, so good?
Yeah.
All right. Let's see here. And, there we go. Come on, slide. Sorry, there we go. I think I clicked too many times. I may get a barrage of them, but hopefully not. So you lead cellular therapy clinical trials at UNC and serve as the principal investigator on multiple CAR T cell therapy trials for lymphoma. And in this role, you oversee logistical coordination, quality improvement initiatives, and strategic planning to support rapid growth of UNC's program, and serves as the clinical director of cellular therapy of the cellular therapy program, where you lead a multidisciplinary team focused on optimizing care for patients receiving CAR T cell therapy, and an MD associate professor in the Division of Hematology at the UNC School of Medicine. All right, and if folks have questions on any of that, of course, we've got a Q&A period section coming up, so you can ask about that, or she has a full day, a full hour for us here. First question, this is always a softball just to get folks going with poll everywhere. CAR T therapy involves modifying a patient's T cells to help them attack cancer cells. True or false? And we'll give our audience 15, 20 seconds. While they're doing that, what's something we should know about you outside of your professional bio there?
Yeah, so one thing that people don't know about me is that English is actually my second language. My first language was Russian. My parents are from Russia and Ukraine, so I grew up, even though I was born in the U.S., I grew up speaking Russian first at home and then learned English when I got to school.
Okay. Well, I definitely did not know that. That's great. And are you still fluent?
Yeah, still fluent.
Russian?
I speak with an accent, but when I speak Russian, but I'm still fluent. My kids can understand some, but not as much. So I think it's losing it in our generation, but of our generation. But still have some.
Well, that's impressive that they know some.
Yeah.
All right. Well, we're leaning 97% true. How are they doing?
Yeah, they're doing great.
Good. Well, with that, CAR T in North Carolina, updates for 2025. I'm going to pass you the mouse and the keyboard and let you take it away.
Yeah. Thank you all so much for having me. I think it's been a few years since I've given the CAR T cell update. And I was kind of looking back at my old slides when I was preparing for this, and that kind of helped me realize how much has really changed over the past 5 years of CAR T cell therapy and where it is right now. So I'm excited to share some of these updates with you all. So to start off, I'm just going to give some of our learning objectives. So because of my specialties in lymphoma, I'll focus more on lymphoma. So at the end of this talk, you'll hopefully be able to talk about some of the recent clinical data supporting the use of CAR T cell therapy in lymphoma. I'll also go over CAR T cell therapy for lymphoma myeloma in general and talk about some of the common as well as some of the delayed toxicities associated with CAR T cell therapy, as well as some recent data around that. And then finally, discussing some best practices for referral and coordination between CAR T centers and local providers. And then if we have time at the end, I'll talk a little bit about future directions and where the field is going next. So just to start off, it looks like you all already know this, but just briefly talking about CAR T cell therapy. So CAR T cell stands for chimeric antigen receptor T cell therapy, and this is a cellular therapy that uses the patient's immune system to treat cancers. And although now, as we'll talk about if we have time at the end, we're moving not just to cancer, but moving to other diseases as well. With CAR T cell therapy, generally is the patient's own T cells, although sometimes it's donor T cells, which are modified so that they can recognize an antigen on a tumor cell and hopefully kill the cancer cell. And one of the big principles behind CAR T cells is finding a suitable target, because in terms of a target on a patient's tumor cell, you want something that can be safely targeted, and also something that's expressed in cancer cells, so you can target most of the cancer cells, but not in normal cells, and so something that can be safely targeted without causing significant toxicity. So one good target is CD19, which is found on B cells. So it is found on normal cells, and it's also found universally in B cell leukemias and lymphomas. But we know that you can safely target B cells with other types of therapies such as rituximab. So targeting B cells is a really good target for CAR T cells. So we have CD19 for leukemias and lymphomas, and then B cell maturation antigen expressed on plasma cells in multiple myeloma. So right now, CAR T cells that are FDA approved are primarily used as treatment for relapse refractory hematologic malignancies, and I'll briefly talk about the approved products in a little bit. And there are commercially approved products in leukemia, lymphoma, and multiple myeloma. And the other thing to know about CAR T cells is that we are trying to move into solid tumors, but it's difficult to find a suitable target in solid tumors. And I'll briefly talk about it if we have time, but there may be issues with trafficking to solid tumor sites. And also CAR T cells require a specialized center to administer the CAR T cells and manage side effects. So this is not a therapy that's available everywhere. So just a brief overview of the CAR T cell process. Generally, we're talking about autologous CAR T cells, which are CAR T cells that are that patient's own T cells. So generally, the process starts off first where patients undergo leukapheresis, where their white blood cells are separated out, and that process generally involves a central line placed by interventional radiology. So patients get a line placed, and then they go to the apheresis lab where their blood is run through a machine and their white blood cells are separated out. Then in the lab, a patient's T cells are isolated, and then a viral vector is used to insert the CAR into the T cell. And then CAR T cells are expanded in the lab and then go through a whole quality process to make sure that they meet criteria to get back treatment to the patient. And this whole process of CAR T cell manufacturing generally takes about 3 to 8 weeks, depending on the product. There are some ways that they're trying to improve and improve the speed of CAR T cell manufacturing so that these can get to patients faster. But generally, this is a waiting period for patients. So that's something to be aware of. And then when the CAR T cells are ready, they're sent back to the center. And generally, before we treat patients with CAR T cells, the patients get preparative or lymphodepleting chemotherapy, which typically is fludarabine and cyclophosphamide. And the purpose of that is to make room for the CAR T cells and produce an environment that makes it easier for CAR T cells to expand. And then after that, several days after the patients get the chemotherapy, they get the CAR T cells. Sometimes it's inpatient, sometimes it's outpatient. And then afterwards, you enter the monitoring period where we monitor patients for toxicities. So generally, when we think about toxicities for CAR T cell therapy, there's short-term toxicities and that we think about that occur generally within the first month, usually within the first 2 weeks. And that includes cytokine release syndrome and neurotoxicity or ICANS, and I'll talk about those in a little bit. Sometimes patients can get coagulopathies, they can get low blood counts, cytopenias. A lot of times initially this can be from the lymphodepleting chemotherapy, and then also infection, also at risk for the chemotherapy they get. Then after about a month, you're thinking more about long-term toxicities, and we think about those are things we need to monitor patients for more long-term, including infection risk. So patients are still in risk for infection, which I'll talk about a little bit later. Kind of persistent sometimes patients get a drop in their blood count again. And then also risk for secondary malignancies or second cancer, as well as sometimes patients can get persistent or neurological problems as well. So when we're thinking about CAR T cell therapy, there's several FDA-approved products for CAR T cells right now. I think 7, and I'll kind of briefly just mention what they are so you're aware. So there's 5 FDA-approved products that target CD19, and those are for leukemia and lymphoma. Lysocell or Breyanzi has the most indications for it, and it's approved both for large B-cell lymphoma in the second line, as well as large B-cell lymphoma later lines, CLL, follicular lymphoma, and mantle cell lymphoma. There's Axicell or Yescarta, which is approved for large B-cell lymphoma second line as well as third line or later follicular lymphoma. And then there's Tisacell or Kymriah, which is approved for later lines for large B-cell lymphoma, and also for follicular lymphoma. And this was actually the first CAR T-cell product that was FDA approved. And it was approved for, the first approval was for ALL, for pediatric and young adult patients up to age 25. There's also 2 more products approved for for lymphoma targeting CD19. There's Brexacel, which targets is approved for mantle cell lymphoma as well as adult ALL, and then there's Obe-cel, which is the newest approval approved in the past year also for patients with ALL. And then we have 2 FDA-approved products for multiple myeloma. There's Ide-cel or Abecma, and then there's Cilta-cel or Carvykti, and they're both approved for multiple myeloma that's pentarefractory, and Carvykti recently also got an approval in the second line for multiple myeloma. So really these treatments are moving on up to earlier lines of therapy. So I'll start off with a patient case. This is a 67-year-old male with a history of large B-cell lymphoma, treated with R-CHOP for 6 cycles. After completion of his initial therapy, he has a PET scan, which unfortunately shows residual lymphadenopathy in the neck, and he has a biopsy which confirms refractory disease. He presents to clinic to discuss options. His past medical history includes a PE diagnosed around the time of his lymphoma, and he's on anticoagulation for that. And he also has a borderline reduced ejection fraction, although that has now recovered, and his cardiac function is back to normal. So how would you treat this patient? And so we'll give a little bit of time.
All right. And
That's
thank
good.
you
Yeah.
all so much for jumping right in and,
So it
sharing
looks
answers.
okay, perfect. So it looks like most people are saying CD19 CAR T cell therapy, and then a few people are saying salvage therapy followed by a stem cell transplant, and a few people are talking about allogeneic stem cell transplant. But it looks like you're getting it right. So let me go through. And then I have one more question for you all. So I'll go through and talk about the data. The answer for that first one is generally CAR T-cell therapy, and I'll talk a little bit about the data about that. But now we have our next question. Which of the following is not an approved indication for CD19 CAR T-cells in large B-cell lymphoma? Yeah. Perfect. Looks like people are answering. Yeah. So the options are second line and primary refractory relapse less than 12 months after initial therapy, second line for patients who are not transplant candidates, relapse after 2 or more lines of systemic therapy, and then consolidation in high-risk patients after frontline chemotherapy. And you're right. CAR T-cells are approved for both second line, early relapsing, and patients who are not transplant candidates, but not approved. There are clinical trials looking at it as consolidation for frontline therapy, but it's not FDA approved for this, and these are still early clinical trials. So you guys got it right. So just briefly going through, so for the longest time, the standard of care for relapsed large B-cell lymphoma after first-line therapy was an auto transplant. So basically patients would get salvage therapy, and then if they showed sensitivity to chemotherapy and were able to get into remission, they would then proceed to transplant. So there have been several challenges with transplant, as some of you already are aware. Many patients are not transplant eligible because of their comorbidities or their age. Many patients are not transplant eligible because they don't respond to salvage therapy. So you may have the goal of getting someone to transplant and you give them more therapy to get them there, but many patients unfortunately don't respond to that therapy and can't get to transplant because of that. So about half or less of patients who were geared for transplant will be able to get to that point. And then in patients who are initially chemorefractory, the question is more chemo really the right option? Or because one of the biggest principle around transplant is a high-dose chemotherapy that is supposed to get rid of deepen patients' remission. So when CAR T-cell therapy was approved for large B-cell lymphoma, there were there were 3 products approved, and there was questions about whether they could be moved up to earlier lines of therapy, with the thought that if you treat patients earlier, their disease may be less aggressive. They may also not be as heavily pretreated, so the quality of their T cells may be better at that point as well. And so there were 3 CAR T cell products approved for large B-cell lymphoma, and all of them had pretty high response rates, over 50%, with complete remissions in the 40 to 60% range, with many complete responders having durable remissions. And so the question was, could these therapies be moved to earlier lines of therapy and potentially replace transplants? So there were 3 clinical trials that randomized patients that were transplant eligible whose disease had relapsed after large B-cell lymphoma after initial therapy. And this was patients who either didn't respond to their initial therapy or their disease had relapsed within 12 months of their initial therapy. And patients were randomized to either get CAR T-cell therapy or get salvage chemotherapy with the goal of getting to transplant. And so there were 3 trials looking at this with the 3 products. Axicell, which is Yescarta, the ZUMA-7 trial, was the first one to report its outcomes, and that was reported in 2021. And there was an improvement in progression-free survival for patients treated with CAR T cells compared to those who were randomized to the transplant arm. Then Lysocell was next. That was in 2022. Also reported a progression-free survival benefit, and also was approved for second-line large B-cell lymphoma. With Lysocell, there was also another trial called the pilot trial that specifically looked at patients who were not transplant candidates. Because these second-line trials randomized patients to transplant versus CAR T, patients had to be transplant candidates for those trials. So with Lysocell, they had a separate trial that was not randomized, but included patients who were not transplant candidates whose disease had relapsed after initial therapy. And that showed similar outcomes to the Transform trial in terms of toxicity and efficacy. So Lysocell was also approved for patients who were not transplant candidates, even if their relapse was later, after a year. And then Tisacel, or Kymriah, that was the last trial, and that trial did not show a difference between CAR T and standard of care. And there's lots of theories about why. Some of it may be due to trial design or specifics of that product. But regardless, there now were two CAR T cell products with benefit over transplant, and making that the standard of care in second line. So here I have the initial curve from of Axicell showing a progression-free survival benefit over standard of care, which was the salvage therapy to transplant. And you can see at 4 years, 42% of patients had not relapsed. So it seems, and you can kind of see the curve is starting to flatten. So it seems like around 40% of patients could potentially be cured with this therapy in second line. And Axicell, the bigger news came 2 years ago in 2023 when they finally reported an overall survival benefit over standard of care. So with Axicell at second line for large B-cell lymphoma compared to standard of care salvage to transplant, the patients lived longer who got CAR T cells earlier. So this was also big news, and kind of further underscores the importance of referring these patients earlier for CAR T cell therapy. And then Lysocell showed a progression-free survival benefit over standard of care as well, but they have not shown an overall survival benefit. And this difference is not. There is a trend towards overall survival, but a difference is not statistically significant. And so there's some questions about why the Axicell trial showed an overall survival benefit while the Transform trial did not. And some of it may be due to trial design. So one of the things we think about when we're getting patients ready for CAR T cell therapy is bridging therapy. And this is a therapy that once patients undergo collection for CAR T cell manufacturing, and their CAR T cells are being manufactured, there's that period of time, the 3 to 6 weeks, while their CAR T cells are being manufactured. And during that time, sometimes patients' disease can become more aggressive, or they may have symptoms. So the ZUMA-7 trial only allows steroids in this setting, while the Transform trial allowed for patients to get a cycle of chemo. So it's possible that there may have been bias in terms of which patients were chosen for a trial. The other issue was crossover to CAR T-cell therapy. The TRANSFORM trial with liso-cel allowed patients on the transplant arm, if they had progressive disease or a poor response, it was built in that they could then get CAR T-cell therapy as part of the trial. And in that trial, 66 of patients in the standard of care transplant arm actually got CAR T-cell therapy, which was more than the number of patients who got transplant. So it's interesting that the transplant arm actually got more CAR T than transplant. The ZUMA-7 trial did not have built-in crossover, but they did allow patients to get CAR T-cell therapy off protocol, and about 55% of patients got CAR T-cell therapy in the standard of care arm, also more than got transplant. So I think people talk about these trials comparing CAR T to transplant, but really they're comparing CAR T to the intent of going to transplant and and potentially second-line CAR T versus third-line CAR T, with second-line CAR T showing a benefit. So this kind of further underscores the importance of referring patients early and considering them for CAR T-cell therapy early. So I think based on these results, we have changed our management and are referring primary refractory or early relapsing patients with large B-cell lymphoma for CAR T-cell therapy. And I think it's important to know that the benefit, you even had a benefit, an overall survival benefit, even though a lot of patients in the transplant arm still were able to get CAR T-cell therapy. And also, I think the other key point here is that for frail patients who may not be transplant candidates, CAR T-cell therapy could still be an option based on the results of the pilot study. So back to our patient case, this patient was seen in clinic and undergoes workup for CAR T-cell therapy. He's initially asymptomatic while awaiting insurance authorization, but then develops worsening cervical and lymphadenopathy and starts having more symptoms. He's able to undergo collection for CAR T-cell manufacturing before starting treatment, but then because he's becoming more symptomatic and because we also want to reduce his disease burden, he undergoes bridging therapy after collection. So while waiting for the CAR T-cells to be manufactured, he gets polatuzumab to try to keep his disease under control and potentially reduce his disease burden. He then undergoes lymphodepletion with fludarabine cyclophosphamide, and this patient is admitted to the hospital for axi-cel CAR T-cell therapy. We're now doing more of it outpatient, but at that time we were still treating these patients in the hospital. And it's good that he was admitted because less than 24 hours after the CAR T-cell infusion, he develops a fever to 101.6 Fahrenheit, no hypoxia or hypotension, so otherwise stable, but a fever. So questions now are, in addition to an infectious workup of blood cultures and initiation of antibiotics, if this patient is neutropenic, what treatment would you recommend at this point? A, acetaminophen alone and monitoring, B, tocilizumab, C, dexamethasone, or D, tocilizumab and dexamethasone. Yeah. Looks like results are still coming in a little bit. Maybe people changing their mind. So I see here, most people said acetaminophen alone and monitoring, but a little bit of otherwise a mix. And there's not necessarily a clearly right answer here. I'll talk a little bit about what's going on in cytokine release syndrome and what we did. But in this setting, you could potentially give acetaminophen alone and monitor this patient because they're stable. You could consider giving tocilizumab just because it's such a fast onset of CRS. Generally, I probably wouldn't do just steroids alone in this case. And if this was someone who was high risk, and I know I'd mentioned that he had this cardiac comorbidities, you could consider giving some steroids as well, though we usually start with tocilizumab alone, especially if they're stable. So here is a cytokine release syndrome, and this is a systemic inflammatory event triggered from the release of cytokines, including IL-6 and interferon gamma, associated with proliferation and activation of T cells. This typically presents initially with constitutional symptoms. Fever is kind of the hallmark sign of CRS. It's really hard to have CRS without a fever, but patients can also have malaise, myalgias. It can affect any organ system, and sometimes it can progress to hemodynamic instability and organ dysfunction. So Grading for CRS used to differ based on the clinical trial and the group. So we initially, when we were trying to compare CAR T-cell products, there were many different grades of CRS depending on the group that was doing it. So grade 2 in one trial may have been grade 3 in another. So it's really hard to compare toxicity profiles. So several years ago, the ASTCT, the American Society of Transplant and Cell Therapy, got a group together which came up with consensus guidelines that everyone now uses so that we're all talking about the same thing. And they really simplified the guidelines a lot, the grading system a lot, which makes it easier for all of us. So with cytokine release syndrome, fever is the defining feature of CRS. And so all patients pretty much have a fever. And with just a fever, it's grade 1. So that patient I just talked about who just had a fever had grade 1 CRS. Then with grade 2, is you start having hypotension and hypoxia, although generally not hypotension not requiring pressors and hypoxia just requiring oxygen. And then once you need kind of require higher needs, requiring ICU care, you're getting into grade 3 and then grade 4. The general treatment for CRS is tocilizumab, and this is an anti-IL-6 receptor antibody, also used by rheumatology colleagues. And this is treated, generally we treat, once patients have any sort of hemodynamic instability, we always give tocilizumab. With grade 1, we used to not give tocilizumab as readily, but now it doesn't seem to impact outcomes, so we're much more free in terms of giving it now. So generally we consider tocilizumab if someone has a fever that persists for greater than 24 hours. And sometimes if someone's high risk, someone with comorbidities who gets CRS, we give tocilizumab earlier on just because we don't want it to progress to higher grades. And then with higher grades of CRS, we start giving steroids, especially if someone's in the ICU. And now we started giving some anakinra occasionally too, which is an IL-1 receptor antagonist. So just in terms of thinking about CRS, I gave you this example of this patient example, but in terms of products, there are differences between Axicel and Lysocell and also between other products in terms of incidence of CRS. So CRS varies based on the type of product you give a patient and also their underlying disease. So for Axicel, in Axicel, most patients get CRS, and that's the product I talked about in this case series. Is generally mostly grade 1 and 2. So either 92% of patients get CRS. So when I'm counseling patients, I tell them, you will get CRS. And if we're treating them outpatient, I tell them they will get admitted at some point. Although, as you can see, in the Zuma 7 trial, only 6% of patients had grade 3 or higher CRS. The timing of CRS for Axicel is about 3 days. The median time of onset is 3 days. So half of patients have earlier onset of CRS, which is why a lot of places still treat these patients inpatient. For Lysocell, which is the other common product we use for large B-cell lymphoma, about half of patients get CRS. So it's a lower rate. And so a lot of these patients may not need to be admitted to the hospital. And in their trial, only a very low number of patients had grade 3 or higher CRS. And the median onset of CRS is later in these patients. It's about 5 days. So it's easier to give this product outpatient because they get CRS later. So for this patient, cultures were drawn and they were started on IV cefepime to cover neutropenic fever. The decision was made to treat this patient with tocilizumab because of the rapid onset of CRS and the higher burden disease, although I think it would have also been very reasonable to wait and monitor this patient and give tocilizumab later. So sometimes it just depends on how the patient looks and the treating team. 48 hours later, the patient still had persistent fevers and mild hypotension, so was given another dose of tocilizumab. And then this patient had more severe hypotension and unfortunately required transfer to the ICU for pressors. And as I mentioned, this is a very rare scenario. I'm giving you this example of a more severe case, but as you can see, grade 3 or higher CRS is quite rare. So this is not something that we frequently see with our CAR T patients. So how would you treat this patient now? Would you give more toci? Would you start Dex? Would you give anakinra? Would you give siltuximab? And siltuximab is an anti-IL-6 antibody. So here it looks. So it looks like some variations. About most people said dexamethasone, which is generally what we would do in this case. I don't think it's wrong to give anakinra here, but generally for our second line for CRS is generally steroids. So this patient was started on dexamethasone, and his symptoms improved significantly. But then the next day, he developed mild tremors and myoclonus. And then he developed increased weakness, started feeling slower in his thoughts, progressing to increased confusion with an ICE score of 6. And I'll show you what that means in a second. He was given anakinra since his neurotoxicity developed while he was already on steroids. And this comes up for us sometimes. And then his symptoms improved. We started tapering his steroids, and then he was discharged from the hospital on day 12. So neurotoxicity, or ICANS, and ICANS stands for immune effector cell-associated neurotoxicity syndrome. And this is just to kind of differentiate it from other things that are non-ICANS, like headache and other neuro symptoms. This is caused by systemic inflammation and cytokine production after CAR T-cell infusion. It drives a cascade of blood-brain barrier disruption, increased vascular permeability, endothelial cell dysfunction, and activation, leading to increased cytokine levels in the CSF. And symptoms can range from delirium and aphasia to kind of seizures, and in really severe cases, patients can get cerebral edema or intracranial hemorrhage, although that's rare. We generally don't give tocilizumab for ICANS because tocilizumab is an anti-IL-6 receptor antibody, so you get transient increase in IL-6 initially, which can cross the tocilizumab doesn't cross the blood-brain barrier, but the cytokines can, so sometimes it can worsen neurotoxicity. So we don't give tocilizumab. We generally treat these patients with steroids, and we've also started giving anakinra more often for these patients. There's also been some reports of intrathecal treatment with either steroids or chemotherapy that can kind of reduce the amount of steroids you're giving, and also allow and some groups have shown had good results with this treating these neurotoxicity with IT intrathecal treatments. So usually neurotoxicity occurs within the first 2 weeks, and initially there was a black box. There was a recommendation on the label for these therapies, CAR T-cell therapies, for patients not to drive within 8 weeks of CAR T-cells, but this recently switched down to 2 weeks, and I'll talk about that in a little bit. So the way we grade neurotoxicity is with the ICE score. This is easier than the MMSC, the mini mental status exam. It's a lot faster. It can kind of be done on the fly by care team members, and it involves questions around orientation, naming, following commands, writing, and attention. And then grading for ICANS, similarly to CRS, there used to be different grading systems for neurotoxicity, and the ASTCT came up with consensus grading for ICANS as well, based on the ICE score, level of consciousness, and then more severe symptoms such as seizure, motor findings, or cerebral edema. And similarly for ICANS, management varies, of course, institutionally, and we keep changing our guidelines based on new data and experiences, but generally the mainstay of treatment for ICANS is steroids, and we also now are starting to give more anakinra as well. So in terms of thinking about incidence of ICANS, this also varies by product. So again, comparing Axicel and Lysocel, ICANS is much more frequent of Axicel, and about 60% of patients in the Zuma 7 trial had ICANS, so while with Lysocel it was only 12% of patients. Again, higher rates of grade 3 or higher ICANS with Axicel at 21% compared to 4% with Lysocel. And the median timing of onset was later with Lysocel as well. So again, there's differences based on products, which may guide selection if you have a patient who you're worried about being higher risk or an older patient. So recently, patients were required to stay within post-CAR T-cell therapy because of these unique toxicities and the and requirement for kind of more specialty care. Patients were required to stay within 2 hours of treating center for 4 weeks after CAR T-cell therapy, and actually many centers, including ours, wanted this to be 1 hour because of the concern about patients being able to come back to UNC if they were having toxicity. And this would also involve them having to stay here with a caregiver. And there was also the rule, as I had mentioned before, of not being able to drive for 8 weeks post-infusion. However, there's a lot of argument about, most of these acute toxicities, as I showed you before, are early and really happening within the first 2 weeks. So it's the Cell Therapy Consortium, which is a group of sites across the country that treat patients with CAR T-cell therapy, look through their published a real-world analysis looking at 475 patients that they treated across multiple sites from between 2018 through 2023 with CAR T-cell therapy for lymphoma. And they evaluated the timing of toxicities. So as you can see here, the majority of CRS and ICANS happened within that first week, with fewer cases happening in the second week, and almost no cases happening past week 2. And they also looked at non-relapse mortality or cause of death in their patients and found that, the first month, ICANS was the most common cause of death, and then later on it became infection. But kind of the key findings here are really that these toxicities are happening early with our patients. And some of these data, as well as other data from clinical trials and just real-world experience, led the FDA recently to change their requirements, and which happened much more quickly than we all expected. But the big change with the FDA is that they got rid of something we call REMS, which is risk evaluation and mitigation strategies, which is a program for medications with higher safety concerns. And more important, kind of more excitingly, from a patient standpoint, they also decreased acute monitoring to 2 weeks after CAR T-cell therapy and decreased driving restrictions from 8 weeks to 2 weeks. And also, this kind of leads us to be a little bit more flexible with our patients getting treatment of CAR T-cell therapy. So a question about this is, will these changes help increase accessibility for CAR T-cell therapy and allow patients to be monitored locally with their local oncologists and not have to stay at UNC or at their treating center for as long? So hopefully, there's a big barrier to CAR T-cell therapies in terms of access, and hopefully some of these changes will allow for more patients to be treated. So back to our patient. Our patient comes back to clinic about 30 days post-treatment. Labs are significant for a white count of 0.8, ANC of 0.2, and platelets of 43,000. PET scan shows an excellent response to treatment. The patient's in a complete remission. And so one question I have is, what is the most common cause of non-relapse mortality in CAR T-cell patients? Cytokine release syndrome, ICANS, neurotoxicity, infections, or second cancers. And it looks like the consensus around the group is infection, which is correct. So now I'm going to talk a little bit about some of these later toxicities for CAR T-cell therapy patients.
And Dr. Grover, I just want to remind our audience that I'm going to go ahead and set up the poll everywhere now so they can begin submitting questions.
Okay, perfect.
Great.
Excellent.
Thanks.
So immune effector cell-associated hemotoxicity is a toxicity that we've seen a lot with CAR T cells. We've seen cytopenias, basically low blood counts of patients post-CAR T cell therapy. And we've also noted that these seem to be more out of proportion than what we would expect just from chemotherapy. And kind of more recently, this phenomenon has been described. So we expect to see some cytopenias due to lymphodepleting chemotherapy post-CAR T cell therapy. Fludarabine and cyclophosphamide cause cytopenias. But we noticed that there was a proportion of patients that had, kind of more, as I said, more cytopenias. So there are some patients that kind of do what we expect, which is the green line in that chart in the middle, where they have their blood counts recover and then they just go on their way. And then that's described as a quick recovery. But then we have these more commonly, or relatively commonly, this intermittent drop or a biphasic drop, where patients may have a drop in their blood counts and then their blood counts then drop again. They have a second dip in their counts, and sometimes this kind of goes up and down. And then the more severe but rare case is this aplastic picture, and that's basically patients basically have a drop in their bone marrow suppression and aplasia, which is refractory to treatment. So there was some interest in figuring out and predicting which patients may have more problems with cytopenias and recently they came up with a CAR hematotox score, which is based on a multi-center cohort of patients with large B-cell lymphoma, and then was later validated in mantle cell lymphoma and myeloma. And this was to identify patients at highest risk for cytopenias. So they looked at baseline blood counts, neutrophil count, hemoglobin, and platelets, and inflammatory markers such as CRP and ferritin. And with these scores, you can basically get a risk score of the risk of having more severe cytopenias after treatment. And then Otherwise, in terms of kind of risks, about 50 to 30% of patients have more profound or prolonged cytopenias after CAR T cell therapy. And the etiology is not really known. It's thought to be multifactorial. It's maybe partially related to kind of the overall hematopoietic stem cell reserve, partially related to patients' kind of bone marrow microenvironment, and then also kind of systemic inflammatory factors and mediators from CAR T cell therapy. And when we see these patients with cytopenias, if it's transient initially, we can support them with growth factors. Sometimes we need to support them with thrombopoietin agonists as well to help with their platelets. But other times, when it's more profound and more persistent, we get a bone marrow evaluation, rule out secondary malignancies, also viral studies, rule out infectious causes as well in these patients. And then in this setting, rarely these patients may need a stem cell boost, although usually outside of myeloma that's not available. And in very rare cases, we've seen reports of patients getting an allogeneic stem cell transplant. So other toxicities we kind of think of are B-cell aplasia, hypogammaglobulinemia, which is an on-target off-tumor toxicity with when you target B cells. And so sometimes patients get IVIG, especially if they get recurrent infections. And then kind of overall, as I mentioned, infection is a big concern post-CAR T-cell therapy. This is initially driven by neutropenia and immunosuppressive therapy from chemotherapy, the lymphodepletion, and also from treatments related to their toxicity. If patients are getting steroids for ICANS or tocilizumab and anakinra, that can increase their infection risk as well. And then kind of later on, this is related to as well to their persistent B-cell aplasia and hypogammaglobulinemia, and it looks like patients also may have kind of more profound lymphopenia, low T-cell counts as well, and at risk for and patients are at risk for opportunistic infections such as PJP and HSV, VZV. So we keep patients on prophylaxis for generally for at least a year post-CAR T-cell therapy as well. So as I mentioned before, in terms of non-relapse mortality post-CAR T-cell therapy, there was recently a systematic review and meta-analysis published looking at causes of non-relapse mortality in lymphoma and myeloma patients. And over half of non-relapse deaths were attributed to infections, as you can see in the blue shade over there, and only about 11.5% of non-relapse deaths were related to CRS or ICANS. One of the other toxicities of concern post-CAR T-cell therapy are secondary malignancies or second cancers. And this can be complicated because these patients are also at risk. These patients are already at risk for second cancers just due to their chemotherapy and their other treatments for their malignancy, as well as their overall kind of risk of second cancers once you have one cancer as well. So these patients have other risk factors, so it's sometimes hard to delineate the cause of that. So there was a study published in New England Journal of Medicine last year of 700 patients treated at a single CAR T center over a 9-year period, and they reported 25 second cancers. 24 of them were either MDS, AML, or solid tumor, but one of them was T-cell lymphoma. So in 2023, the FDA issued and so the T-cell lymphoma was particularly interesting because in 2023, the FDA surprised us all and issued a black box warning around T-cell malignancies seen post-CAR T-cell therapy. And this was quite surprising and to the CAR T community because it was not something we had really seen. There's always this theoretical risk that CAR T cells can cause through insertional oncogenesis can maybe activate a cancer gene or changes in T cells to make them more cancerous, and that could lead to malignancies, but that's not something that we had really seen. And in this particular case of T-cell lymphoma, this seemed to be a molecularly distinct immunophenotype and genomic profile, and there was no evidence of oncogenic or retroviral integration, so it was felt not to be related to CAR T-cell therapy. In the same issue of New England Journal of Medicine, they also published another report of a T-cell lymphoma after cilta-cel, which is a BCMA CAR T for myeloma. And this case report was a patient who developed intestinal T-cell lymphoma about 5 months after CAR T to treat multiple myeloma. And then they found evidence of the CAR gene in the T-cell lymphoma cells and did whole genome sequencing and found that there was in both in the tumor and in the blood, and found that there was this insertion site within specific genes. So they thought in that case that this likely was potentially related to the CAR T cell therapy. But this is very rare and kind of really reported in case reports. So I'm going to skip over this for the interest of time, but going to our patients had neutropenia that improved with growth factor. The patient's count recovered by 2 months post-CAR T-cell therapy, and then the patient continued to be in remission at 2 years post-CAR T-cell therapy. So moving on, briefly, there's another case of a patient with multiple myeloma who developed grade 2 CRS treated with tocilizumab, and also around day 14 noticed a peak in their white blood cell count. You saw a big rise in their white blood cell count as well. And then around day 25, the patient is noted to have slowed movements, decreased verbal output, an exam noted to have inattention, masked faces, hypophonia, intention tremor, and cogwheeling, and a very slow and shuffling gait. So this is another toxicity that we think about, particularly with BCMA CAR T-cell therapy with multiple myeloma, and they're called kind of movement and neurocognitive toxicity. And this is felt to be something separate from ICANS. These are movement disorders, cognitive impairment, personality changes. The immediate onset is around day 36. The MRI tends to be normal in these patients, or they sometimes may have changes in their basal ganglia. This is generally seen about 5% of patients in one of the clinical trials for multiple myeloma CAR T. So it's not very frequent, but it's something that is seen. And so one of the risk factors that we see is these are patients who oftentimes have that bump in their white count, which is their CAR T cells expanding after CAR T cell therapy, and that seems to be a kind of a harbinger of these patients who are at higher risk for these neurotoxicities. So sometimes we also see cranial nerve palsies. The facial nerve is the most frequent as well, also in these myeloma patients as well. So something to be aware of for these myeloma patients is these movement disorders that can occur. And these these are generally managed with steroids. The other toxicity that was recently discovered in myeloma patients was this immune effector cell-associated enterocolitis. So this was reported last year, 14 cases of enterocolitis after CAR T in multiple myeloma, and in their series at about a 1.2% incidence. And so these patients had acute onset symptoms with non-bloody diarrhea, a negative infectious workup, a median of 3 months post-CAR T. So these are later patients, right, when they're back home a lot of the time. Their gut biopsies tended to show inflammation, and in one case they did see CAR T cells. And these patients were treated with steroids, and some patients who were steroid refractory got infliximab. And I think something to note is that 5 of these 14 patients died from either bowel perforation or sepsis. So this is a serious toxicity. It's rare, but something to be aware of in these myeloma patients post-CAR T. And this just also kind of further emphasizes that we may see new toxicities or new signals that were maybe not seen in clinical trials for these therapies as we use them more. So it's important to kind of be aware of that when you're taking care of these patients. So just, I think kind of just a big point from all of this as well is that as we're working to improve outcomes for CAR T cell therapy, one of the biggest, most important things is kind of coordinations of patients, kind of patients' local oncologists and local oncology teams. One of the biggest issues is that before we even think about improving outcomes for CAR T cell therapy is that the majority of patients who are eligible for CAR T patients don't even get there. So I think it's just kind of getting the patients to our centers, getting the patients evaluated for CAR T cell therapy, because there's a lot of patients who are probably eligible for CAR T cell therapy who aren't getting it, and trying to reduce some of those barriers. So I think it's important for these patients to be referred early before they get too sick to get CAR T cell therapy, and also that frail patients may be candidates for this therapy. And then it's also important to kind of coordinate their bridging therapy with the treating center, communication, and then also for providers treating patients with CAR T cell therapy, it's important to communicate back to the referring center about toxicities and late toxicities to be aware of. So now kind of moving forward towards future directions for CAR T-cell therapy, some of the things we're thinking about in the future include studying these therapies in earlier lines of therapy for heme malignancies. So we're moving these therapies up. So as I mentioned before in that question, there are trials looking at CAR T-cell therapy for consolidation of high-risk patients after frontline therapy. So there are trials looking at patients at earlier lines of therapy as well, and trying to get to patients before their T cells are as beaten up, before the disease gets so aggressive, so maybe curing patients earlier. There's also interest in improving CAR T cell therapies with dual targets. So a CAR T that targets both CD19 and CD20 for lymphoma. So that way, if you get antigen lost, you may overcome some of the resistance. So there's trials in the works for these newer CAR Ts and comparing them to the standard of care CAR Ts as well. There's also interest in off-the-shelf approaches, so CAR T cells that are from donor T cells, so you don't have to from patient donors, so you don't have to wait for CAR T cells to be manufactured and are not using patients' own T cells from patients who are immunosuppressed. And then there's also interest in vivo CAR T cell therapies, where CAR T cells are where you CAR T cells are manufactured in the patient's body, so that this is also an exciting field moving forward. As I mentioned before, we're also moving to solid tumors and moving towards CAR T cells to overcome some of the resistance for solid tumors, so looking for good targets for solid tumors, and also trying to overcome some of the barriers of solid tumors in terms of trafficking to the tumor site or the inhibitory microenvironment with solid tumors. And we have several trials at UNC for CAR T cells in solid tumors as well, including breast and pancreatic cancer, glioblastoma, where the CAR T cells are infused intraventricularly, and ovarian cancer, where they're infused intraperitoneally, so really getting to the tumor. And then finally, as I mentioned before, CAR T cells are also moving for autoimmune diseases, so moving outside of oncology. So that's kind of where the field is going next as well. So with autoimmune diseases, targeting B cells similarly to lymphoma can have good outcomes. So there was interest in kind of resetting the immune system with CAR T cell therapies and treating patients with CAR T cells targeting B cells to treat their lupus. And we actually have several autoimmune trials at UNC, including CAR T trials for lupus. And this was given permission to share from our patients. We've treated several lupus patients at UNC with really good outcomes with CAR T cell therapy. And these are patients who also have disease, like a patient who had lupus affecting every major organ system, had a terrible quality of life, and got CAR T cell therapy and is doing so much better. So these also have therapies that have promise in other diseases as well. So we may start seeing them outside of oncology too. With that, I know I went a little over. Hopefully you have a little bit of time for questions, or if you wanted me to elaborate on any of that. But thank you very much.
Thank you so much. This is outstanding. And we have 133 people in attendance, so that's excellent. So right off the bat, why are CAR T patients not treated with anti-epileptics prophylactically?
That's a good question. So we do treat some patients. with anti-epileptics prophylactically. Some of it depends on the CAR T cell product. So CAR T cells, have risk of seizures. Some CAR T cells have risk of seizures or neurotoxicity. And so with some products for CAR T cell therapy that are higher risk of neurotoxicity, we do sometimes give patients Keppra as prophylaxis, or in patients who are at higher risk. There's some products like where you don't have that as high of a risk for neurotoxicity, and some of these anti-epileptics still have some toxicity for some patients. So just trying to limit extra medications. And there's not clear data whether the anti-epileptics help in this setting, but we do use them prophylactically in high-risk patients. So that's a good question.
All right, and here's another one. Thank you so much to our audience for sharing these. What investments is UNC making to support its CAR T ambition and growth?
That's a really good question. So I didn't get a chance to talk about it as much, but at UNC we have a cell therapy, adaptive cell therapy a lab where CAR T cells are manufactured at UNC off campus in a UNC lab. So we have our own clinical trials. So we have had investments kind of from the University Cancer Research Funds and from philanthropy that fund some of these clinical trials that are moving to newer indications. And we're also trying to expand, also in addition to expanding clinical trials that are made at UNC, which is kind of our top priority to really kind of get UNC research to our patients. We also have other innovative clinical trials open as well, and have fantastic clinical trial staff as well as a fantastic clinical team staff of nurses, social workers, advanced practice providers, financial teams that are taking care of our patients too. So we're definitely and pharmacists, and our team is definitely growing as well. So we have a fantastic staff as well as a great research lab where CAR T cells are being manufactured.
Great. Thank you so much. And then one more, and then we probably are getting to the end of our time. To get more eligible CAR T patients to UNC, how is UNC leveraging and engaging its referral networks and community sites?
That's a really good question, too. I think a lot of it is just through events like this, and also through communicating with providers. So we have relationship with local oncologists. Some of them are UNC networks, and some of them are other providers that refer to us a lot, where we try to share the data with them, with our mutual patients, and also try to get those patients that are referred to us really quickly into UNC really quickly. We also have some other programs, like sometimes seminars where we share some of the recent data with the referring providers as well. And there's also through things like grand rounds where we go and kind of share some of the recent data as well. So I think some of the communication with these local providers, and now kind of as CAR T patients maybe move back earlier, a lot of it will also involve kind of education around some of the later CAR T toxicities, so that they can also we can co-manage these patients together.
Great. Thank you so much.
Thank
you can pass the keyboard and mouse, I'll go ahead and bring us through a couple more slides. We want to say thank you. Thank you to the State of North Carolina, the University Cancer Research Fund, UNC Lineberger Comprehensive Cancer Center, Veni Obore, John Powell, Oliver Marth, Andrew Dodson, Patrick Muscarella, and Kimberly Riddick. Each of them puts a lot of work into each and every one of these lectures, so we really appreciate that.